The topic of lecture is root canal filling materials and root filling techniques. This lecture outlines such questions. Objectives of root canal sealing, tools for obturation of root canals, International Standard Organization standards, filling materials, classification, composition, properties of different groups of sealers, indications for use, techniques of root canal sealing with gutta-percha points, methods of single cone, cold and warm lateral condensation and vertical condensation of gutta-percha, thermoplasticized gutta-percha techniques such as thermofill and obtura, importance of coronal filling in maintaining endodontic treatment success, and mistakes and complications during root canal sealing. So after root canal were appropriately instrumented and washed with antiseptic solutions, it is ready for sealing. And actually that is the next essential step after instrumentation. And what is obturation? According to the American Association of Endodontists, obturation, it is the method used to fill and seal cleaned and shaped root canal using a root canal sealer and core filling material. We have such goals of non-surgical endodontic therapy, and they come to such. Root canal systems must be cleaned and shaped, cleaned of their organic remnants and shaped to receive a three-dimensional hermetic fluid-tight seal, filling of the entire root canal space. Such objectives of root canal sealing: to prevent bacteria and bacterial elements from spreading from or through the canal system to the periapical area. The fully instrumented root canal has to be provided with a tight and long-lasting obturation from the coronal opening to the apical constriction. A root canal filling material should therefore prevent infection, reinfection of treated root canals, together with an acceptable level of biocompatibility to be inert material, and this will provide the basis for promoting healing of the periodontal tissues and for maintaining healthy periapical conditions. Such criteria can be proposed for effective obturation, and root canal pre-obturation should correspond to such criteria. First of all, to be sufficiently enlarged and tapered, to have appropriately formed apical stop, do not contain a necrotic dentine, do not have a typical gangrene odor, do not have a painful reaction to percussion, to be clean and dry. This is important, to be clean and dry. Pay attention to the lateral canals, main canal and lateral canals. They as well should be appropriately sealed. And we start from instruments. So apical obturation instruments are designed to help clinicians to pack gutta-percha or any other material, for example MTA, into shaped and cleaned root canals. These instruments can either be a hand instrument used to physically place and pack the material, or as a syringe designed to place materials in the canal by pushing on the planka. Such instruments, hand instruments that fixed into conventional hand piece, Lentulo spiral filler. Pay attention to its working end. Here you have its magnifying working end. It's like a spiral. So it's small flexible instrument used with contra-angled slow speed hand piece. Necessary to use this instrument cautionary because it can be fractured if it is placed too deep inside the root canal. This instrument always should be free inside the space of root canal, should not be blocked. If blocked, it leads to fracture. Finger spreader. Function of this instrument is to condense gutta-percha laterally to one of the walls inside the root canal. It looks like a metal blank that smooth and tapered, and pay attention to its magnifying working end. Here it is. Plugger can be a hand instrument or finger instruments. These instruments is used to pack gutta percha inside the root canal vertically. Yeah, I have said it can be a hand instrument and finger instruments. Pay attention to the design of the working tip. It's like a blank of metal that has cut on the end of its tip. That's why it can easily condense vertically the gutta percha inside the root canal. Obturative materials. They fall in such two big categories: sealers, fillers. Sealers. They fill the space between the canal wall and co-obturation material and may fill lateral and accessory canals, isthmuses and irregularities in the root canal system. Fillers, they can be solid or semi-solid materials. Solid, it is silver or titanium or acrylic cones. Semi-solid, it is gutta percha pins. Actually, these materials are designed to fit snugly into a canal enlarged to an equivalent dimension. By the way, silver pins right now is of historical interest. They were replaced by gutta percha points. Sealers. We start from sealers. So the most popular sealers are grouped in this way: zinc oxide eugenol, glass ionomers, calcium hydroxide sealers, paraformaldehyde sealers, resin-based sealers, and this one, silicone-based sealers, calcium silicate-based sealers. These were introduced at the beginning of the 21st century. According to Grossman, every sealer should possess such ideal criteria. To be tissue tolerant, it means that it should not cause any irritation or destruction of the tissue. No shrinkage with setting. It means that sealer should remain dimensionally stable or even expand slightly on setting. It should have slow setting time. The sealer should provide adequate working time for placement and manipulation of obturating materials and set reasonably soon after obturation. Adhesiveness. A truly adhesive material forms a tight bond between the core material and dentin. And about this criteria, I will stress my attention when we would talk about resin-based sealers. Radio opacity. So sealer should be X-ray contrast, that the dentist can normally check the quality of root canal sealing after obturation. Absence of staining. So remnants of the paste should not stain dentin or enamel. Solubility in solvent. So this property is very beneficial if it goes about retreatment procedures. Insolubility to oral and tissue fluids. So sealer should not resorb when it has contact with oral liquids. In a case of coronal filling loss. It should have good bacteriostatic properties, should be able to kill microorganisms, and at least not to encourage their regrowth. And has a great ability to create a seal. So, and this is obviously an important physical property. The material must create and maintain a watertight seal apically, laterally, and coronally. Nowadays, none of the available sealers on market possess all of these qualities at the same time. Some have more qualities, some have less qualities, but once again, such sealer with these ideal properties was not invented yet. All of them have some advantages and disadvantages. So zinc oxide eugenol sealers. This is considered to be sealers that widely used, and they have a great history of usage. Basically, they start their history at the 1930. So at the beginning of 20th century, they were introduced in endodontology. These sealers possess they have a very good advantage because if they are extruded into the periapical tissues, they have ability to be resorbed. Due to the presence of hydrocortisone or dexamethasone, such anti-inflammatory drugs, they possess anti-inflammatory action to the periradicular tissues. So to some extent, they can stop inflammation in periradicular tissues. They can promote a healing of periradicular tissues due to steroid anti-inflammatory compound in their composition. In 1961, company Care produced Tublicil. It is resin polymerized zinc oxide cement. It is manufactured till now. So advantages of Tublicil: it is quick and easy to mix. It provides high lubrication, and it doesn't stain teeth, and it expands after setting. Disadvantages: it irritates periapical tissues. By the way, you should keep in mind that every sealer is toxic to some extent. That's why extrusion of it through the periapical tissues leads to post-operative sensitivity and discomfort of patients. Continue with disadvantages. So it has very low viscosity, easy extrusion through apical foramen, short walking time, rapid set, especially in the presence of moisture. But nowadays, the company produced a new formulation, Tublicil Express, and this sealer has extended working time, and it is available in auto mix tube. So 2 compounds placed in this syringe, and in equal portions can be placed on a mixing pad and sealed into root canal together with gutta percha. So these sealers are used with gutta percha. Glasionomer sealers. They were introduced at the same time when glasionomers were introduced for restorative purposes. So in 1976, Padford recommended endodontic glasionomer sealer, has the name Ketak Endo, company 3M, as a root canal sealer. But due to its positive qualities, it has the very great disadvantage that overlaps the positive qualities. It is difficult to do retreatment. This material was not solvent at any solvents. That's why nowadays this material not manufactured anymore. Glass ionomers, and they are basically rarely used as a sealers. For these purposes of root canal sealer, non-surgical management of root canal. Possibly they can be used in a retrograde sealing, but it's doubtful. New materials with better qualities were developed. So we talk about it like a historical aspect right now about glasionomer sealers. Paraformaldehyde-based sealers. I put here this Forident, Spofa Dental, Czech Republic. So Forident, paraformaldehyde has in its composition actually aldehyde, and you know that aldehyde causes mummification action to vital tissue, fixation of it. Moreover, any microorganism can survive. So paraformaldehyde possess bacteriostatic effect, but at the same time they are toxic and provide some toxicity to periradicular tissues. So in United States, the use of paraformaldehyde sealers are contraindicated. Once again, because few modern compositions are developed. But anyway, this material is manufactured nowadays and has its indications. For example, in a case of mummification, such method we had, mummification method, it can be applied in sclerosed, obliterated, curved root canals when it is hard to do proper instrumental endodontic treatment to the full length of the root canal. So this paste provides vaporization of aldehyde and thus mummification of the pulp remnants inside the root canal. So we may consider that pulp tissue would be mummified there and no regrowth of microorganisms would be. So basically advocated in old-aged patients to whom impossible do normal root canal treatment to the full length with appropriate tapering of the root canal. So this is the method of choice and the material of choice for this group of patients. It's considered to be so. Another group of sealers, it is calcium hydroxide sealers. These materials can be used as inter-appointment medicaments, but their rationale in this case is unclear. However, they can be left within the tooth for long periods of time when trying to induce apex closure or arrest root resorption due to their osteogenic potential. So properties, like first, due to high pH, 9-12, this sealer creates a cytotoxic effect that stimulates the formation of a secondary dentine and thus helps formation of the root to its normal length or apex closure in a case of loss vitality of teeth if this root is not normally formed, immature roots. So in these cases, this material is used and indicated. Another property, it is bactericidal properties. Due to alkaline environment, any microorganism can survive. Easy to manipulate, rapid hardening in oral environment. The drawback, it is soluble in acids and washed out if there is no tight obturation by temporary dressing, and they does not bond to dentine. That's why they cannot be used at the permanent restoration, only as inter-appointment medicament to sterilize the root canal and provide root formation to its normal length or apex closure. And actually, this continuous release of calcium hydroxide leads to material solubility, so cannot be used as a long-lasting tight obturation purposes. Calacept, actually, it is the example of this material of calcium hydroxide that used as inter-appointment medicament. Indications of calcium hydroxide use include to promote apical closure in immature teeth, in the management of perforations, in the treatment of resorption as a temporary dressing for canals where filling has to be delayed, in the management of recurrent infections during root canal treatment. Such examples of calcium hydroxide sealers. By the way, these examples that are placed here, they can be used as permanent restoration with gutta-percha points. But that what I said before, Calacept, unfortunately I didn't put here in the examples, it is used as inter-appointment medicament and promote this material promote closure of the apical foramen in the case of apexogenesis or apexification. So this calcium materials such Cielapex, company Care, Apexit Plus, company Ivoclar Vivadent. It provides Apexit Plus, and right now they develop a new material, Apexcal. Cielapex, non-eugenol calcium hydroxide polymeric resin. Pay attention, polymeric resin, root canal sealer. Available in paste formulation. So such properties has Cielapex: induce mineralization, induce apical closure via cementogenesis, inhibit root resorption subsequent to trauma, inhibit osteoclast activity via an alkaline pH, seal or prevent leakage, as good as or better than zinc oxide sealers, less toxic than tin oxide sealers. If it goes about Apexit plus, it has such advantages. It is excellent, has great biocompatibility, durable sealing. Due to the slight setting expansion, its easy flowing composition allows the material to adapt well even to morphologically complicated canals. Fast, easy application due to auto-mix syringe and intracanal tip enable easy direct application. Extended working time. Mixed Apexit Plus can be used over 3 hours at room temperature. And once again, stress your attention that these two materials that here in examples, they are permanent obturation materials used with gutta percha. Mineral trioxide aggregate, MTA. Such material, it is calcium-based materials. And it was developed by Mahmoud Torabinejad as a dental root repair material in 1994. So composition of this material: powder composed of the small hydrophilic silicate, phosphate, and tricalcium oxide particles. With the addition of silicon oxide and bismuth oxide, which make it X-ray contrast. Properties: pH level is 10.2 and 12.5 after curing. So it has as well great antimicrobial activity, similar to that of calcium hydroxide. It is biocompatible. It doesn't react or interfere with any other restorative material. It has low solubility, works well even in the presence of moisture. Actually, a moistened cotton pellet should be placed in contact with MTA material before placement of the permanent restoration. It needs moisture for better polymerization. It has low resistance to compression, so not strong enough, but actually to be strong enough, if it goes about root sealing material, it's not so important quality because stress inside the root canal is not present. But the setting time is around 3 or 4 hours. So it was the qualities of MTA materials. Such indications they have can be used in pulp capping procedures if it goes about vital pulp procedures, such as pulp amputation. Tak? Next, it can be used in a pulpotomy, or in the cases of pulp regeneration, if it goes about conservative method of treatment of pulpitis. In the case of perforations, lateral perforation, perforation of the bifurcation, essential root resorption, in the procedures of, in the treatment of teeth that have not appropriately formed root to its normal length, if it goes about apexogenesis, and in the case if vitality of tooth loss before its normal growth to the full length, we talk about apexification. And in the surgical procedures, if it goes about retrograde sealing and apexotomy. or apicoectomy. So these are indications for MTA material. Such materials are available. ProRoot, company Dentsply, ProRoot MTA. It is resorbable, biocompatible, waterproof, indicated for apical formation, repair of iatrogenic perforations, repair of absorptions, retrofilling, and coating of the pulp, pulpotomy procedures. Completely hardens after 4 weeks. Such material as biodentine Septodont. It can be used on both crown and the root. So it used as a linings as well if it goes about lining in the case of acute deep caries. So versatility of use can be used in both endodontic and restorative procedures. It saves times thanks to the direct bonding with the composite. The tooth will react by generating dentine, which will preserve the vitality of the pulp. When I have prepared this lecture, I have found information that actually MTA material is considered to be bioceramics material, so keep it in mind in case. Apexogenese. I have put here this slide to explain what is apexogenese, because I was talking about it, apexogenese. So apexogenese, it is treatment procedure by which the preservation of the radicular pulp tissue allows continuing development and apical maturation of teeth with open apices. And actually here you have this open apex. Pay attention, it's similar to the radicular apoptosis, but actually it's open apex and not appropriately formed root canal. But vitality was lost. So we talk about pulpitis, inflammation of the pulp. Inflammation of the pulp. Here you have the calcium hydroxide material or MTA material, and in some time, half a year or year, the normal growth of the root with appropriate apical closure was obtained. Of course, it is recommended to provide appropriate root filling, endodontic treatment and appropriate root filling after the normal formation of the root were obtained. So endodontic treatment is essential step after formation of the root and apex. Actually, these materials just promote formation of the root to its normal length. Apexification. Apexification, it is treatment procedure by which closure of root apex is promoted by calcium hydroxide in teeth where loss of vitality has occurred before normal growth and development of the tooth was completed. In the case of apical periodontitis, when we talk about apexogenese, I have mentioned pulpitis, and in the case of apical periodontitis, we need to talk about apexification. So the same procedure, MTA material or calcium hydroxide material is placed into root canal orifices, and in this case there won't be normal growth of the root to its full length, but just be apical closure, formation of the calcific barrier, and the root would obtain just closure without normal growth of the root to its full length. The time required to barrier formation can be variable with times from 5 to 12 months. And of course, after that, again, a normal endodontic treatment with appropriate root sealing. Bioceramics. In endodontics are the modified hydraulic calcium silicate-based materials that are used for a variety of procedures, including vital pulp therapy, regenerative endodontic procedures, management of immature permanent teeth, root canal therapy, repair of root perforations, and as a root and filling material in apical surgery. So basically the same indications as for MTA material. And by the way, these calcium silicate sealers, they are an outgrowth of the like the branch from the MTA material. That's why they have the same indications for their use. But their properties were improved, including physical, chemical, and biological characteristics. So they developed at the beginning of the 21st century. Examples of bioceramic sealers, such as Endo CPM sealer, Buenos Aires, Argentina, MTA Philapex, Angelius, Brazil, Bioroot, Septodont, Tech Biosealer, Profident, Kielce, Poland. So here you have these examples, and in particular propose to look close in the MTA Philapex, Angelius, Brazil. So it is mineral trioxide aggregate-based salicylate resin root canal sealer. It is designed to provide a high flow rate and a low film thickness for easy obturation. And it has such advantages. Biocompatible, rapid recovery of tissues without causing inflammatory reaction, high radio opacity, perfect radiographic visualization, excellent flow. It is designed to flow into lateral canals even. So satin expansion, it is another positive quality. It provides excellent sealing of the root canal, avoiding the penetration of tissue fluids and bacterial recontamination. Calcium ion release induces rapid tissue regeneration in sites with bone lesion and microbial activity, and easy removal in the case of retreatment. Particularly when this material is used with gutta-percha points. It is available in paste formulation and available in syringe. So MTA Philapex. The first, what I want to say, that resin-based materials rely on, so they provide adhesiveness. They adhere to the dentine, but to have appropriate adhesive properties, necessary to remove smear layer from the root canal. That's why some materials possess this ETA solution inside their composition, but some don't possess ETA solution in their composition. That's why recommended to use this separate ETA solution for removal of smear layer. So I wrote here, it is not sealer. It is just extra supportive ETA-based solution that is used pre-resin-based sealer application to remove smear layer. And smear layer is created on the canal walls by manipulation of the files during cleaning and shaping. It is composed of inorganic and organic components that may contain bacteria and thereby products. In theory, remnants left on the canal wall may serve as irritants or substrates for bacterial growth or interfere with the development of a seal during obturation. That's why such examples of ETA solution I put here. So ETA 70% percentage solution, or Smear Clear Cibron Endo company. And the benefit of this material that it is without special smell. It is water-soluble solution that contains 17% ETA salts. Technique of applying ETA. After the root canal was shaped, cleaned, ETA solution can be placed on a paper point inside the root canal, coating all walls of the root canal, or just irrigate from a syringe for 1 minute, and after irrigation should be followed with a final rinse of sodium hypochlorite. Only in this case would be done appropriate debridement and decontamination of root canal. Resin-based sealers. So we were talking about this ETA solution because it's essential, the first step prior applying resin-based sealers. So these resin-based sealers are classified on epoxy resin and methacrylate resins. Here it is epoxy resin, this example. These resin-based sealers, they have a long history, and they are as well popular as zinc oxide eugenol sealers. Basically, it is two the most widely used sealers in the dental market, and not for nothing, because they provide good sealing and adhesive properties, and of course antibacterial activity. However, they produce some initial severe inflammatory reaction, especially if they are extruded out of the apex, and that's true. So keep in mind that sealer should be inside the root canal, in the borders of the root canal. Resin-based sealers, together with some irritative reactions, could cause some allergy and mutagenic potential, and of course it can cause paresthesia. But all of this can happen if this material is extruded through the apical hole, through the physiological apical hole. As a mistake of usage of this material can be developed a toxical apical periodontitis. Due to toxicity of this material. By the way, formaldehyde, that is in the composition of resin-based materials, provide antibacterial effect. Nowadays, company Dentsply manufacture this material H+. It is resin-based sealer with excellent radiopacity, low shrinkage, low solubility, and outstanding flow characteristics. So available in paste-paste formulations, easy to mix, easy to introduce, biocompatible, and silver-free. It's very important because in prior materials, silver were present. So resin-based materials cause staining to enamel and dentine, but in this material H+, silver is not present. So used with gutta-percha, H+. Examples of methacrylate resin-based sealers. Actually, these materials rely on adhesiveness. They possess adhesive properties to the dentine. No, because they are used together with ETA solution. So such examples: Endores. These methacrylate resin-based sealers, they have their generations. This one, Endores, it is second generation. About first one, I don't talk because this is not manufactured anymore due to certain drawbacks. And basically, second generation still is in manufacture in dental market and is used. So we talk about Endores as a second generation of methacrylate resin-based sealers. It contains urethan dimethacrylate. It has hydrophilic properties. It's very important and beneficial. That's why it even demands some amount of moisture inside the root canal. So this dry, the criteria of being dry is not so important if it goes about using this Endores material. seal best when applied to moist interradicular dentine and used with either conventional gutta-percha points or specific endo-res points, resin-coated points. Meta AdSeal company, Meta material AdSeal, available in syringe as well. It is a fourth generation of methacrylate resin-based sealers. It is a permanent root canal sealing. It has thermal obturation and advantages. Biocompatibility is of excellence, easy to mix, hermetic sealing, non-staining to the teeth, insoluble in tissue fluids, and of course X-ray contrast. Epiphany, company Care Endodontics. As well, syringe, two pastes available in syringe. They have their adhesive system, ethoxylated bis-GMA, bis-GMA bisphenol A and glycidyl methacrylate. And this material as well has its own gutta-percha points, specially coated. Calcium, coated by calcium hydroxide material, barium sulfate, barium glass, and silica. This is the composition of these fillers. It's not the gutta-percha, it's their own fillers, specially designed for this material, Epiphany. But it can be used, this Epiphany sealer can use as well Resilon points. Resilon, it is thermoplastic synthetic polymer-based root canal points, which contain bioactive glass, bismuth, and barium sulfate. And in this case can be achieved excellent seal by creating a monoblock. And this key fact, to create a monoblock, to provide 3D tight obturation. As you see, when they were produced and developed in 2004, such technique of applying Epiphany prior to the application of primer, 70% of ETA is used to remove the smell layer. Then we should rinse with saline or 2% of chlorhexidine, dry with paper points. Then mixing of sealer from the dual syringe mixed with auto mixing tip. Applied into the canal using Lentulo spiral filler or master cone. Such properties. X-ray contrast, easy to remove, dual curing, hydrophilic, biocompatible, non-mutagenic, non-cytotoxic, improves the fracture resistance of the roots. And we move to fourth generation of methacrylate resin-based sealers and Real Seal. Real Seal as well, pay attention to this kit. Sealer in syringe, adhesive system, micro brushes, reusable tips, specially designed Resilon points, the same that can be used together with Epiphany. This kit has in their composition adhesive system, but this company, courtesy Sibron Endo, provide nowadays new material, Real Seal self-edge sealer. So in this material, there is no necessity to apply ETA solution, washing with chlorhexidine and do all that extra steps. It's self-edging. So just apply this material into the root canal. So saves the time for the dentist and optimize the working time in general. Real seal, it has such advantages. It is biocompatible, non-toxic, and non-mutagenic, leak resistant. Unlike gutta-percha, real seal leaves no gap for leakage. It's important, it's a positive quality. Coronal and apical leakage are substantially reduced, strengthening. It gives the root significant toughness. Technique compatible. It works with current filling method that deals with gutta-percha, similar. Retreatable, can be removed with chloroform or heat, and radiopaque. Here you have the set of real seal once again, specially designed points, primer, adhesive, and syringe with two pastes. So how the sealer can be introduced into the root canal. Here you have the list of possible ways how the dentist can introduce sealer in the root canal. By lentulospiral filler, using master cone of gutta-percha and pumping the cone up and down in the canal, placing the sealer on a file and spinning it counterclockwise, just coating the walls of the root canal, using syringe, directly inject, if material is available in syringe, and activating an ultrasonic instrument. And a key point, the clinician should use care when placing sealer in a canal with an open apex to avoid extrusion, because sealers are toxic when they set. Technique of root canal sealing with paste. If it goes about only paste, and we don't talk about gutta-percha, this can be used for calcium hydroxide sealers that are used with gutta-percha, and zinc oxide eugenol-based sealers. So we put, first of all, prepare the paste according to the manufacturer's recommendations. Then rotary paste filler should be dipped in a prepared sealing material. Some amount of the material should be taken on it and placed into the root canal by careful movement to the apical part of it, and then take back a little bit the canal filler, because canal filler should be free in the space of root canal, and then can be start rotation. And the dentist can check by his vision, that paste obturate the space of the root canal. Rotation is, here you have these ranges of the rotation, 600-800 revolutions per minute, and sealing material is distributed into the canal space, providing obturation. And after 10-15 seconds of rotating, a rotary paste filler in a rotating mode, it's important, in a rotation, should be removed from the root canal. So it is a technique to seal the root canal with paste, only with paste, not gutta-percha, stressing your attention again on it. Now we are on fillers, so we can talk about fillers. So gutta-percha, it's a gold standard of co-obturation material, and it has been used for years, for decades of years. What is gutta-percha? First of all, it is purified coagulated latex obtained from motherwood trees, which are found both wild and cultivated in Malaysia and Indonesia. I put here even this picture for you to understand what is the tree, how it looks like in general, to attract your attention to this. And gutta-percha points, right? They are available in different sizes, color-coded, on the top of this gutta-percha point, there is color coding, same to the endodontic instrument. With different taper, it can be 0.4 or 0.6, it depends, or some special tapers are available. Even we have taper for ProTaper files. So this available in different sizes and different tapers. So it up to all demands of the dentist. Such advantages and disadvantages this material have. Advantages: it is compactable, inert, can be softened, it has good dimensional stability, it is tissue tolerant, radio opaque, easily removed, antibacterial, and readily sterilizable. Disadvantages: lacks rigidity, lacks adhesive quality, does not bond to sealers by itself, easily displaced by pressure, and has a lack of length control. So it's actually a disadvantage grade. It has such physical and thermomechanical properties. Gutta-percha is thermoplastic and viscoelastic material which is temperature sensitive. At ranges of ambient room temperature, it exists in a stiff and solid state. It becomes brittle on prolonged exposure to light and air due to oxidation. It becomes soft at 60 degrees and it melts around 95-100 degrees with partial degradation. Decrease in temperature increase the strength and resilience, and vice versa, especially when temperature exceeds 30 degrees above zero. The physical properties of tensile strength, stiffness, brittleness, and radiopacity depend on the organic gutta-percha polymer and wax resins and inorganic components, zinc oxide and metal sulfates. Actually, here you have the composition of gutta-percha. And zinc oxide increases brittleness, decreases percentage elongation, and ultimate tensile strength. So it was the physical and thermomechanical properties of gutta-percha points. Gutta-percha available nowadays in different modifications because new techniques develop, new criteria to different materials evolved. That's why gutta-percha as well respond to these demands. And nowadays we have such modifications. Surface modified gutta-percha, it is resin coated. We were talking about gutta-percha specially designed for Resilon and Real Seal, Endores, glass ionomer coated gutta-percha. We will talk about it in the case of active gutta-percha. Bioceramic coated non-thermal plasma, medicated gutta-percha that has in its composition iodoform, calcium hydroxide, chlorhexidine, tetracycline. Actually, these materials possess antibacterial effect, and at the same time, gutta-percha, there is a consideration that gutta-percha that is coated by these medicaments will release some antiseptic and thus would be effective against Escherichia coli or Fusobacterium or Kinomyces or Enterococcus fecalis. So different gutta-percha that is covered by these medicated substances possess its own special activity and can be chosen according to a certain case. And don't forget about nanotechnology. So nanoparticles as well are present in gutta-percha, and we have nanoparticles enriched gutta-percha. So nano-diamond gutta-percha composite biomaterials and silver nanoparticles coated gutta-percha. Of course, nanoparticles improve physical properties of material. And here you have the techniques for root sealing with gutta-percha. They classified in two categories: solid core techniques and softened core techniques. Solid core techniques can be single cone and lateral compaction, lateral condensation. Softened core techniques are warm lateral compaction, warm vertical compaction, thermomechanical compaction, injection molded gutta percha, and core carrier. In particular, I will explain about each of these methods of sealing root canal with gutta percha. So, single cone method. The main idea of this method that a root canal wall is coated with sealer, and then master point of gutta percha. What does it mean, master point? It should correspond to the size of the apical part of the tip of the gutta percha should correspond to this last size of file that was used for shaping this apical part of the root canal. And the main idea that apical gutta percha master cone should snugly close this apical part of the root canal, obturate it very tightly. For that reason, it should correspond to the size of the instruments that were used as the last. And that's it. That is the main idea of this single cone method. But this method has several disadvantages and cannot be considered as one that seals canals completely. So after preparation, root canals are seldom round throughout their length, except possibly for the apical 2 or 3 millimeters. Therefore, the single cone technique in general seals only this apical part of the root canal and don't co-interact with the walls of the root canal. There is a sealer. Lateral condensation, widely used method, preferable by numerous dentists with different sealers, and technique is such. Gutta percha, a similar idea, root canal wall is coated by a sealer, and then master point is inserted into root canal to fit the apical closure, and then and then it is pressed by finger spreader laterally, and then extra points pressed, and again finger spreader is inserted and condense gutta percha laterally to one of the walls. And this process is repeated until the entire space of the root canal is filled with gutta percha points. And then excess of gutta percha points cut with heated instrument. Basically, here I have put all these steps that I have explained right now, and after the root canal were sealed, of course it is essential step to do X-ray to check the quality of root canal obturation. Here you have a sketch of cross-section. In the middle part of the root canal, here you have the master point, sealer, and extra points of gutta percha, and in the apical part cross-section, so tightly obturated apical part of the root canal, if it goes about lateral compaction of gutta percha. Warm lateral condensation, as above, but uses a warm spreader after the initial lateral condensation was done. Finger spreader can be heated in a flame or a special electronically heated device, touch of heat, for example, and then pushed inside the root canal and pressed vertically to the walls, trying to melt the gutta percha. So similar idea as lateral condensation, but with a heated instrument. Vertical compaction of gutta percha. Gutta percha in small particles placed inside the root canal and vertically compacted with a plugger, with a hot plugger. and this procedure is repeated until the whole space of the root canal would be filled with gutta percha. So put one small particle of gutta percha, then again, and all of that vertically compact with the help of plugger, vertically compacted until the whole space of root canal would be obturated with gutta percha. Thermoplasticized gutta percha technique. Actually, this so the concept of injecting softened gutta percha into the root canal was introduced many years ago as a development of vertical condensation, like a development of the vertical condensation of gutta percha. So this technique involves injecting of molten gutta percha into the root canal system. Theoretically, it is simple, but this technique demands considerable care and is associated with the disadvantages of any thermoplasticized material. Even though it has been recommended for obturation of the complete root canal system, it is probably prudent to use the injectable heated gutta percha as a backfilling material after an apical plug has been established. As with all gutta percha obturations, a sealer must be used. So it's key point. And the commonly used systems include the Obtura system, high heat, and Ultrafil, low heat systems. Obtura system, Obtura B, Obtura 2, Obtura 3, different modifications available. Obtura Max, as I see on my picture, I put this picture. Anyway, principle is similar. Gutta percha that is heated in this device, in this syringe, is injected directly into the root canal. You pay attention, 160 to 100 degrees. It is that temperature under which the gutta percha melted. Different sizes of this needle available, 20, 23, 25, through which gutta percha is injected into root canal. As the gutta percha leaves the tip of the needle, its temperature drops to between 65 degrees and 65. The heating barrel reaches full operating temperature in less than 2 minutes, thereby eliminating the need to preheat the gutta percha. So it's very easy and fast. Moreover, such injectable gutta percha provides tight obturation and 3D obturation of root canal. Even we can talk about lateral canal obturation, and this is important because inside the lateral canals still there is, if it is not obturated, there is spaces where microorganism can regrow, and lateral canals considered to be connections with periodontium. So lateral canals is essential to be obturated, and actually this injectable gutta percha technique, thermoplasticized gutta percha, promotes it. Low heat ultrafil system, such syringe available that is used to inject gutta percha inside the root canal. Canules must be placed in the heater at least 15 minutes before use and must be discarded after 4 hours heating. The trigger is squeezed gently and released, and the gutta percha is allowed to flow out. And it is important to avoid excessive pressure in order to prevent extrusion of the material from the canal. Ultrafil, such system, and Thermafil, or coated carriers. These are cores of metal or plastic coated with gutta percha. They are heated in an oven and then simply pushed into the root canal to the correct length. The core is then served with a burr and a dense filling results, but again, apical control is poor and extrusions common. This technique is expensive and difficult in retreatment. Here you have these core carriers. Here you have this device in which they should be melted before placing inside the root canal. And it seems to be simple. You hit this coracia, insert into appropriately shaped, appropriately tapered root canal. I'm sure that it's available in the tapers. Taper is 10. Mo gutta-percha fills up to 10 taper, so different tapers available. That's why they provide tight obturation from the apical to the coronal part of the root canal. And as well, it can be introduced into lateral canals. And this handle removes after gutta-percha tip were inserted into root canal. So it was thermophile or coated carriers. Active gutta-percha. Active gutta-percha, it is gutta-percha points that are coated with glasionomer cements. It is available in such kit. We have gutta-percha points that is coated by glass ionomer and special glass ionomer resin-based sealer. This technique develops as a result of the idea that glass ionomer possess great co-interaction with dentine tissues due to formation of ion exchange mechanism. Active gutta-percha works in single cone method. Like this is schematic representation. So different tapers available. Sealer is used to coat walls, and then this gutta-percha point coated by glass ionomer inserted into root canal, and it should tightly close the root canal, but only in a single cone method it works. Several researches were done to check the quality of root canal sealing with active gutta-percha point, with H+ material, and with Resilon points. And as a result of it, it turns out that still there is a micro leakage if it goes about active gutta-percha use, because this single cone method is not effective enough, despite it creates a monoblock. And actually this monoblock technique is very good and very positive. That's why this good idea. But anyway, in comparison with other techniques, there were micro leakage, significant micro leakage. For example, in comparison to usage of Resilon, Real Seal, or H+ with gutta-percha points. So necessary to think about it and to choose that what appropriate for a certain clinical case and for a certain dentist and patient. Gutta-Flow, it is silicone-based gutta-percha, cold, not heated. Obtura thermophile, it was heated injectable gutta-percha. A Gutta-Flow, it is cold injectable gutta-percha. So as well available in such triturator with special cannules that provides easy injection of this material inside the root canal. So it is gutta-percha powder incorporated into incorporated with silicone sealer. We have unidose capsule that are injected after mixing for 30 seconds in a standard triturator, followed by placement of single master cone. Again, single master cone. Working time 15 minutes, setting time 25-30 minutes. The material fills canal irregularities with consistency, and it is biocompatible. Advantages: no heat, no shrinkage. Sealer and gutta-percha in one material. Exceptional flow plus expansion, no condensation required. adheres to gutta percha and dentine. Solubility, here you have 0.0, contains microsilver that provides optimum protection against reinfection of the root canal, but don't provide any staining or discoloration. So it was Gutta-Flow, called injectable gutta percha. Gutta-Flow. And quality of root canal sealing. Basically, I have introduced you with almost with all materials with several examples. Of course, few more exist, and they are numerous, and it's impossible to check everything and present everything at once. That's why with root sealing materials and fillers we have finished, and we are on the quality of root canal sealing. So the optimal preparation obturation length for root canal, it is apical constriction. So sealer should stop at this point and don't go far. And to locate apical constriction, necessary to use apex locator or use specially designed tables with mathematically standardized lengths of the root canal. Different ways available, but apex locator is the most reliable one. For necrotic pulp, root sealing should be 0.51 millimeter away from radiological apex. For vital pulp, actually it is apical constriction. Here it is, 2 millimeters from the anatomical apical foramen. And here you have such schematic representation of root sealing. Sealed to physiological opening, so it's okay. Sealed to X-ray opening as well, it's okay if it goes about necrotic pulp. Underfilled, pay attention, not enough root sealing, and overfilled, like too much, it is in periodontal tissues. Of course, this can be checked by X-ray. The quality of root canal sealing is checked normally by X-ray after root sealing. Together with appropriate root sealing, appropriate techniques, appropriate material, we cannot forget about final crown restoration, because final crown restoration plays great role. Both design and placement of the final restoration are critical, and this aspect of treatment is an integral part of obturation. The restoration acts as a protector of tooth structure, and if the myriad of irritants, such as substances of saliva, microorganisms, food, chemicals, and other agents that pass through the mouth, gain access to periapical tissues, they may cause inflammation and treatment failure as a result. So if coronal gutta percha with sealer obturation is exposed to saliva, dissolution of sealer and leakage over a relatively short period of time may occur, and this results in leakage of bacteria, toxins, and chemicals into and around the gutta percha. The consequences of sealer loss are obvious. Communication from the oral cavity to the periapex or periodontium will eventually be complete via lateral canal or apical foramen. So coronal exposure of the obturated material for more than a short period of time through loss of restoration, recurrent caries, or open margins requires retreatment. The time of exposure requiring retreatment is underdetermined, but probably depends on varied factors such as quality of obturation, length of canals, and surface area of exposure. And now we are on mistakes and complications. So the principal objectives of endodontic therapy are to clean and shape the root canal system and to fill the canal system completely in 3 dimensions. This aimed to prevent penetration of bacteria and thereby products into the periapical tissues and develop as a result hermetic seal. Inadequate obturation of root canal system results in failure of endodontic therapy. It has been shown that about 60% of endodontic failures are due to incomplete obturation of the canal space. And another problem that can face the dentist, it is timing of obturation. So we have such widely occurred mistakes: overfill, underfill, lateral canal sealing, and timing of restoration. So overfill. Overfills are undesirable under any condition because it leads to inflammation of periodontal tissues and post-operative pain. Sometimes it can lead even to necrosis or toxical, allergical response. So it's prohibited to do so. It's a great mistake. By the way, histological examination revealed a great inflammation in the areas of overfilling. Underfill. Underfill results when both preparation and obturation are short of the desired working length, or when the obturation does not extend to the prepared length. Either instance of failure to treat a canal may contribute to treatment failure, particularly long term. You can trace here sealing material, but it is not to the end of the root canal. Here it is the ending of the root sealing, and still some amount of root canal is empty. So underfill is undesirable because as well microorganism can persist there, but it is not as dangerous as overfill, because anytime that if dentist do X-ray and check that root canal is underfilled, he can continue refilling and improve the quality of root canal sealing. But in the case of overfilling, there is no way to remove back. In the case of underfill, dentist can improve sealing after X-ray was done. Lateral canal sealing. Pay attention on these X-rays. You can see these lateral connections with periodontium. So there is idea that this connection exists, and in a case if obturation is not 3D, not tight, micro contamination, micro leakage can be present, and thus the possible release of microorganisms through these microcanals into periodontal tissues can lead to periodontitis. Like, pay attention, in this case it was periapical like inflammation on the lateral side of the root canal. Possibly somehow it can interfere the quality of the root canal sealing. Anyway, tight and 3D obturation is important, and actually some techniques, thermoplasticized technique of gutta-percha, provides this long-lasting and tight obturation for root canals, including lateral canals. Timing of obturation. So sometimes the question can arise: when is treatment to be completed? Is it time to obturate? And to decide this, we need to answer for the question: is it vital pulp or is it necrotic pulp? In the case of vital pulp, if we talk about pulpitis, the treatment obturation should be at the same day as root canal instrumentation was done, and there is no necessity to put it on a second visit. So for vital pulp, root canal treatment with tight obturation should end at the same appointment in 1 day. If it goes about necrotic pulp tissue, when we talk about apical periodontitis with the symptoms of pus, abscess, percussion, of course, such tooth cannot be sealed at the same visit. There is a necessity to do it on the next visit, or even in few visits, because dentists can leave in the root canal special medicaments such as calcium hydroxide material or any other medicaments to provide antiseptic and anti-inflammatory effect to the periradicular tissues. But if the tooth is asymptomatic, apical periodontitis of chronic cause, such technique exists to do root sealing at one visit, and there is no necessity to divide it on few visits. But everything depends from the condition of the patient and the state of the periradicular tissues, of course. And from this lecture, we can derive such three important conclusions. The first one, an up-to-date knowledge of various materials for root obturation is essential to ensure the selection of the most suitable material in a certain clinical situation. Second, the quality of the root canal filling depends on the complexity of the root canal system, the efficacy of canal preparation, the materials and techniques employed, as well as the skill and experience of the operator. And third, filling of the canal does not represent the end of root canal treatment, as the restoration of the tooth crown is critical to prevent leakage of fluids and oral microorganisms into the pulp space, thus providing long-term success. And such books can be suggested for you to as a further reading. Cohen's Pathways of the Pulp, Principles and Practice of Endodontics, Dora Binejad, Textbook of Endodontology, and of course, Engel's Endodontics. Okay, so that's it. Thank you for attention and have a good day.